Yeah, ma. Hello, hello everyone. Nice to
Hello,
see.
hello, madam. How are you?
I'm fine. I'm fine.
I'm Dr. Manan Doshi. I work in Sahyadri Hospitals at Pune.
Oh wow, that's great. Nice to connect digitally. Yeah, ma.
Yes,
Hello,
ma'am.
hello everyone. So we are
Good evening,
live
ma'am.
now.
I am Dr. Sudeep. I'm working at Command Hospital, Lucknow, ma'am.
Yeah. See, I know most of you. I mean, the thing is again now
We keep
seeing
meeting
you.
you, ma'am.
Yeah. We've seen you in all conferences and all that. But yeah, it's really nice.
Dr.
Hi, Dr.
Ma'am,
Manisha.
now we are live on Teams.
Hello, Dr. Rishi. How are you?
Good. All well? Nice.
Yeah, going on.
Yeah. So
Life
Seems
is
just came to
running.
learn
That's it.
something today. So we'll
You
stay
people
mute and
already know
quiet.
everything. It's a repetition of whatever you know
No,
already, and
no.
we
We are
learn
just
from
going
each
to
other all the
stay
time.
quiet and learn a little. Thanks.
No, it's always a process of two-way learning. I mean, there are
Yes,
so
it
many
is.
things, and everybody has so many experiences of their own.
True.
So it's nice.
Hi, Dr.
Seema ji,
Simi.
are we live?
Yes, so we
I
are
think
live.
we are live now, and
Yes.
Done.
Manan, you can
Okay.
start.
Good evening and welcome to Nephrocon. Tonight's session is a topic at one of the most consequential intersections. It's a place where nephrology meets obstetrics and where two lives hang in balance, and the misdiagnosis can affect both the lives. Pregnancy associated AKI PRAKI. It is not rare, and the numbers and consequences are in our part are even more sobering. The question is whether we can recognize this kidney injury early to really make a difference. And to guide us through the current understanding of diagnosis and management, we are privileged to have Dr. Manisha Sahai. She is the professor and head of nephrology at Osmania Medical College and Osmania General Hospital, Hyderabad. She's also the co-author of AKI 30-second consensus statement of PRAKI, uh, one of the authoritative guidance for this condition published in 24. She brings both global evidence and regional experience to this session. Uh, Joining her on panel are two distinguished clinicians, Dr. Sudeep Prakash, he's from Command Hospital, Lucknow, and Dr. Tushar Dige, he's professor and head of nephrology from DPU. I would ask Dr. Sahai to start the session, and we can have a detailed discussion once the talk is over. Over to
Right.
Manisha.
Yeah. So thank you all. It's a pleasure and honor to be here, and it's a process of continuous learning. Everybody has their own experiences, and everybody can bring something to the table. So, with that background, I'll be focusing on the topic given to me. Just a second, let me share my screen. Yeah. Okay, so are you able to see? Is it okay? Hello?
Yes, madam, we are. Yes,
Yes,
we are.
sir.
Yeah.
Yes, ma'am.
Okay, fine. So the topic we are discussing today is the current understanding in diagnosis and management of PRAKI. So it's a very relevant topic. Why is it so? It's so much relevant for our country. As you can see, look at the numbers. We have 26 million annual deliveries in India compared to the other developed countries, almost 10 times as many. And look at the number of doctors handling these deliveries. So it's dismal. So almost less than a third of what they have in the developed countries. So that's why PRAKI is very relevant to our setting. And this slide should be remembered by all of us that in this day and age also about 10% of all our AKI, as you see in the right side circle, it's because of PRAKI. 10%, that's a huge number. And this is in contrast to what we see in the developed world, which is around 1%. So you have several studies, and these figures I'm stating from the article mentioned below. But otherwise, remember, we have a PRAKI 10 times more than we have in the developed world. So now coming to the diagnosis of PRAKI. So how do we do it? So we start with the case, 28 years primipara, no significant medical history previously, natural conception. The pregnancy was absolutely normal, no history of hypertension in pregnancy. She delivered 3 days ago at 36 weeks gestation, and the delivery was by LSCS for cephalopelvic disproportional. It was not for nephro indication. There was no history of blood loss or hypotension, absolutely fine. The baby was 2.8 kg, female baby, healthy. And now she has come to our unit 3 days since the section, and she's complaining of decreased urine output since the day of cesarean section, and it's reported in her file from the gynec hospital that she is passing around 200 ml urine per day since the section. And now she's admitted with breathlessness and also has swelling. She is pale on examination and the blood pressure is 140 by 92 millimeter mercury. So this is how she was received in the nephro unit post 3rd day of delivery. And these are the reports she carries with her. Urine shows 1+ protein, RBC 1 per hyperfield. There are no casts, WBC 3 per hyperfield. UPCR is 0.4. And LFTs, the RFTs are significantly deranged. Creatinine is 4.5 milligram per DL. Electrolytes are normal. The bilirubin is high. Indirect bilirubin is high, indicating hemolysis. The liver parameters seem to be normal at present. LDH is quite high, even at presentation to us. The urine culture, blood culture reports which have been done are negative. The viral markers are negative. Coombs test is negative. It's available from gynec hospital. And the INR seems normal. She also has a peripheral smear showing schistocytes. Hemoglobin is reported as 7.7. Leukocyte count seems normal and platelets are low at 88,000. So you can see the peripheral smear clearly shows schistocytes for her. The ANA profile, which was done at gynec hospital in our Telangana government setup, was negative. The kidney size was normal on ultrasound. This was done there at the gynec hospital. And there was no dilatation of the pelvic ileocecal system, at least in that report. So the admission PG has put this diagnosis, pregnancy-related AKI with hemolysis, anemia, thrombocytopenia, and the gynec PG has made a diagnosis of postpartum preeclampsia with a probability of HELP syndrome. Now let us see how far we are or how close we are to the real etiology. So this is a common scenario which we encounter. Most of the cases of PRAKI we get in our center are postpartum, and this is generally the presentation they come with. Now, first thing is, when do you call it a pregnancy-related renal dysfunction? So remember, pregnancy-related is AKI which occurs during pregnancy or within 6 weeks postpartum, diagnosed by KDIGO criteria in a woman with previously normal kidney function. And Our Lady definitely fits into PRAKI by this definition. And as the moderators were mentioning, the AKI group also has defined PRAKI in their own way. They say AKI due to pregnancy-specific pathologies such as preeclampsia, hyperemesis, or obstetric hemorrhage, as well as AKI which develops because of any other coincidental causes during the period of pregnancy and postpartum. So Our Lady fits into this definition of PRAKI as well. So pregnancy-related we understood, either pregnancy or postpartum. 6 weeks. What about the definition of AKI in pregnancy? We all know the non-pregnant definition of AKI, that serum creatinine rise of equal to or more than 0.3 milligram per DL in 48 hours and a fall in urine output or a fall in urine output less than 0.5 ml per kg per hour for 6 hours. This we all know. But remember that the KDIGO nor the ACOG give any separate definition of PRAKI. So do we need a separate definition of PRAKI, that is AKI in pregnancy? Definitely yes, because pregnancy physiology is different. We know the GFR increases and the normal values of creatinine go down in pregnancy. So a non-pregnant AKI definition may not be suitable, but as of now, this is the best we have. So if the rise in creatinine is more than 0.3 milligram per DL, as I said, in pregnancy, we call PRAKI. But in Indian setting, what happens is there is no normal value of creatinine prior to the admission. No baseline value is available most of the times. So what do you do in such cases? So then you compare the patient's creatinine with the expected values in pregnancy. We know that the expected values in pregnancy are lower than the non-pregnant state. Generally between 0.4 to 0.7 milligram per DL is what we expect during pregnancy. So if you don't have any baseline value of creatinine, then look at the pregnancy specific values and compare. Remember, even a normal looking value of creatinine 1 milligram per DL should not be neglected, because that itself indicates some renal dysfunction. It's suspicious. You have to follow. And remember, trends are important. So within 48 hours, if there is a rise, definitely you can confirm that it's a case of PRAKI. So don't be worried if you don't have a baseline creatinine. So this lady, as per the staging of AKI, fell into the stage 3. Creatinine was already above 4. She had severe renal dysfunction. So we have understood that she has pregnancy-related AKI. Now, how do we go about finding out the cause of this? So we know that we have different causes in pregnancy. The first trimester common ones are septic abortion, hyperemesis gravidarum, and any other cause of AKI which can occur in non-pregnant state as well, volume, drugs, etc. Remember, hyperemesis gravidarum is quite uncommon. We have hardly seen a case so far. And septic abortion also is coming down, luckily, because now abortions have been made legal. So this is coming down. That's very fortunate. Now, in the latter part of pregnancy, these are the PRAKIs which we get nowadays. So either they occur post 20 weeks in the last trimester of pregnancy, and the most common ones we all know are hypertensive disorders of pregnancy, either preeclampsia or HELP. So that occurs generally antepartum, can occur postpartum as well. And in addition, you also have thrombotic microangiopathies, the TTPs, which generally occur during the third trimester of pregnancy. And you have HUS, which generally occurs peripartum or postpartum. So these are important causes, the preeclampsia and the thrombotic microangiopathies. The other important thing in our country is postpartum sepsis or puerperal sepsis, another important cause, and obstetric hemorrhage. So these are very important causes. You have acute fatty liver of pregnancy there as well, but it's generally not a cause of severe renal failure in pregnancy, may present more with deep jaundice. So these are the causes which we have to identify. So our PG has made a diagnosis of preeclampsia with HELP. Now we have to find out whether it is that only or whether it can be any of the other 5 disorders, because the treatment is different. In addition, look at the orange bars. Any other non-pregnant AKI because of glomerular disease or because of any infection, tropical causes can also occur in pregnancy. And we have to keep that at the back of our mind. So we have pregnancy-specific causes and we have the general causes. So this is by MENA, a systematic review where they found the commonest cause of PRAKI in a developed country is preeclampsia, whereas in underdeveloped country, it is sepsis. So this is a recent paper and still shows that sepsis plays an important role, followed by obstetric hemorrhage and preeclampsia. However, in our study, where we have studied 395 PRAKI cases over 10 years, which was published in JAPI, we could find out that preeclampsia is becoming common now. 45% were because of preeclampsia. Sepsis was 33% and obstetric hemorrhage was around 20%. So these are the 3 main causes of PRAKI. Keep those in mind, rule these out first and then think of anything else. 75% of our cases were postpartum. So what about our patient? So she doesn't have any other cause, incidental causes. She was perfectly normal, and post 3 days after delivery, she has ended up with AKI, hemolysis, thrombocytopenia, and hypertension as well. So what could it be among these causes? Let us see one by one. Could it be preeclampsia? If we just put a diagnosis of preeclampsia, PRAKI, is that correct? She fits into the definition of preeclampsia, hypertension, more than 140/90, occurring after 20 weeks. And as I said, 1/3 cases of preeclampsia can occur postpartum also, even after a normal pregnancy. And we know that we call it preeclampsia when hypertension is associated with either proteinuria or any other renal organ dysfunction. So proteinuria more than 0.3 gram, we all know that. Even if proteinuria is not there, if along with hypertension, you have a low platelet count or hemolysis or renal dysfunction, or you have liver transaminases, which are elevated, or if you have pulmonary edema, CNS manifestations, meaning any other organ dysfunction plus hypertension, then this could be preeclampsia. And Our Lady definitely has these parameters and could be preeclampsia. So preeclampsia, without any other complication, generally AKI occurs in around 5 to 10%. And treatment, we know BP control and delivery. So most important point against preeclampsia in this lady is preeclampsia recovers after delivery. So generally the trends of creatinine go down, and anything persisting more than 72 hours have a high index of suspicion for something else. Don't just say that it's preeclampsia. It might be, but bring other parameters into mind as well. What about HELP? So HELP is associated with preeclampsia, and it is a little bit severe disorder. Again, AKI can occur in 30 to 60%. The triad is generally there: hemolysis, elevated liver enzymes, and low platelets. And here the outcomes are poorer than preeclampsia. Mortality is also high. The treatment again for HELP syndrome is, if the patient is antepartum, immediate delivery. So generally postpartum HELP is uncommon, and it also starts improving within 72 hours. So our lady can still have a HELP syndrome. Liver enzymes are normal for her, the initial value at least. So these can be considered, but again, the most important clue is the trends in the disease pattern, and it is very important for postgraduates because many of these preeclampsia and preeclampsia mimics have similar features. So the course is important. If a PRAKI is not improving within 3 to 4 days post-delivery, think of other conditions as well. So any other new biomarkers for diagnosis of preeclampsia? So we know till now we look at the proteinuria and LDH, liver, creatinine, all those things. So we know that the pathophysiology depends on the imbalance of anti-angiogenic and pro-angiogenic factors. So we have high anti-angiogenic factors, SFLT, and low pro-angiogenic factors, that is placental growth factor. So putting simply, the ratio of SFLT by PLGF is high. PLGF is a good molecule, SFLT is a bad molecule. So if higher SFLT and lower PLGF, it's likely preeclampsia. And you have values, and the labs are doing these tests as well. So more than 85, less than 34 weeks is likely preeclampsia, and more than 110, more than 34 weeks of gestation is again likely preeclampsia. But again, remember, what do the guidelines say about using these biomarkers? They should not be used alone for diagnosis. They have to be used in combination with other factors. There are a lot of studies, and this the postgraduates know, the PARROT study, INSPIRE, and PRAKI, all three say that angiogenic biomarkers are good for diagnosis and also for helping with the timing of delivery, predicting preeclampsia, but in association with the traditional features what we use, not alone. And this is what the guidelines have said. These tests are not routinely recommended. And the ISSHP says that should not be used as a sole criteria for diagnosis. So we should be aware of the cutoffs, but remember that they are not compulsory for diagnosis and they are not available all the time. So we did not send these markers. So as of now, preeclampsia, HELP, okay, that's at the back of our mind. It fits the picture, but only thing is, the trends of creatinine are worsening and not improving. There is no recovery at all, and the patient has crossed 72 hours. The second problem was puerperal sepsis, which I said was common in India. But in this lady, puerperal sepsis can occur up to 42 days postpartum. Common causes are UTI or even retained products, poor asepsis, and kidney damage may be pre-renal or renal, AIN, ATN. So many things can occur in the biopsy if we need to do a biopsy. But this lady was non-toxic, no fever, no vaginal discharge, no breast tenderness at all, no foul-smelling lochia. This we should always ask. We should never forget. And the vaginal swabs were negative. High vaginal swabs were negative. There was no leukocytosis. CRP was normal. Cultures were all negative. So puerperal sepsis unlikely in our patients. So that is the second diagnosis which we have ruled out clinically. Is it obstetric hemorrhage? That's the third important differential. But no history of bleeding, no history of blood transfusions, no retroplacental clots reported, no hypotension at all. So we deemed it unlikely. Acute fatty liver of pregnancy. So that's the fourth differential, very unlikely. So it is an important cause of PRAKI, but remember, the renal failure is generally mild. The patient presents in the third trimester, not after delivery, because generally it improves after delivery. And the patient generally gets admitted to a gastro ward because of severe jaundice, hypoglycemia, and low levels of fibrinogen. So you won't find such patients in the renal ward not undergoing dialysis or anything. So unlikely cause, uncommon cause of PRAKI, and we didn't think of it in this patient. You have Swansea criteria for acute fatty liver of pregnancy. I'm not discussing those. It's an unlikely cause of PRAKI. Now, the other two important differentials we talked about were thrombotic microangiopathy. So apart from preeclampsia, sepsis, obstetric hemorrhage, these are the ones which you should never miss, because TTP, this presents like a preeclampsia, presents in the third trimester, generally antepartum. And here the problem is deficiency of ADAMTS. And what does this ADAMTS13 do? It cleaves the von Willebrand factor. So simple words, you can see in the insert, there's a blood vessel and there are long fibers stretching from the walls of the blood vessel. They are all multivers of von Willebrand factor. So what happens is, if the enzyme is not there, they hang out in the circulation and they block the flow of platelets, and platelet thrombi result. So that's the cause of TTP and there is endothelial damage as well. So this is a crude, simple way of explaining because that's not the topic today. So TTP can be a cause of PRAKI. Special features are, remember, think of TTP when the platelets are low. Generally, the counts will be very low, 30,000 something. Renal failure, again, remember, it would be mild, generally not requiring dialysis. Creatinine, generally levels are low. They won't be high. Less than 2 creatinine may be in favor of TTP, not more than that. Coagulopathy is absent here. And the diagnostic test is ADAM-TS. We look at the activity. We also look at the mutation. Unfortunately, expensive, and we don't send it all the time. It's important not to miss this PRAKI mimic. I call it a preeclampsia mimic. We should not miss it because the treatment is specific. You have to do a plasmapheresis, which you won't be doing otherwise. And plasmapheresis changes the outcome. 90% renal failure comes down to 10%. So never ever miss this. Keep it in mind whenever you have very low platelets and a mild renal failure. So ADAM-TS may not be available all the time. Clinically, what you can do on the first day when you receive the patient, look for friend score and plasmic score. The basis of these scores is the creatinine value and the platelet count. And looking for other factors, they are all available online. So if these are normal, you can fairly rule out a TTP. So this was done in our patient. The platelets were not very low. The creatinine was not very high. So definitely low plasmic score, low friend score. Clinically, we ruled out TTP. ADAM-TS level was sent. Remember, always send these levels before starting any form of therapy. Store them properly. Cold storage is required. Freeze immediately and send before doing any therapy. Send before doing a plex or a dialysis. That's important. But if you think of TTP, do not delay. Start immediately. Send the reports and start the therapy immediately. In our patient, we had ruled out TTP clinically. Now, the last differential is atypical HUS. So this is also another form of thrombotic microangiopathy. And how does it differ from TTP? It occurs mostly postpartum. It's because of defects in alternate pathway of complement. Again, hemolysis is there. Thrombocytopenia is there. There is no recovery post 72 hours. So whenever this is a strong differential of postpartum preeclampsia, recovery within 72 hours, think of preeclampsia. More than 72 hours, creatinine is increasing, think of HUS. Again, hemolysis, this patient had high bilirubin, had high LDH, cystocytes were there. So fits in with atypical HUS or complement-mediated HUS. We should keep that also as a differential. We can't confirm it at this point of time, but cystocytes are uncommon in preeclampsia, can definitely be seen in TMAs. Here we need to pick it up because, again, early starting of eculizumab is important and it improves the outcome 70% ESKD without eculizumab to less than 10% with eculizumab. So the thing is, this happens all on first day when you receive the patient, that you do the basic tests, give the therapy, draw the samples and start therapy, meaning dialysis, plasmapheresis if it's TTP, or if it's HUS, you have to apply and try to get eculizumab. Sooner the better. So what did we do now? So we have clinically thought that it might be HUS, still that preeclampsia is in our minds. So we have collected and sent the blood for complement, ADAM-TS and genetic analysis. All were sent. Reports not available. Reports are going to come after 2 to 3 weeks. So complement were sent. We know that these are the normal levels of complement for the sake of postgraduates. We should know these levels. We don't have the levels right now. Patient has been admitted a day before and this has been sent. Genetic testing has also been sent. Remember, for the genetic testing also, we can send it anytime. The sample should be in cold storage. And again, the reports are going to come after 2 to 6 weeks. But again, don't wait. Send it off. Let the results come when they come. And genetic testing, you should know what panel to send. So complement factor H, I, MCP, C3, CFB, THBD. So all these things, DGKE, PLJ, Informin, and the methylcobalamin metabolism mutation. So all these are sent as a panel. So many of them are being done in India in the corporate centers and in center at Pune. Generally, we send our reports there. So this is what we have ordered and sent before starting any therapy. Clinical diagnosis, as of now, we think it's PRAKI related to probably HUS on clinical grounds. What do we do now? We are waiting for the results. So what sort of a treatment we start? We stabilize the patient. We try to determine the cause and give specific therapy. dialysis as needed. And if it were to be antepartum, we would have done delivery. We would have planned for delivery. Stabilize means look at the volume management. We know that we should be very careful with the volume, because hemorrhage, you have to give fluids. If it's preeclampsia, you have to restrict. You can't overload. Patient goes into pulmonary edema. So we use the clinical criteria as well as focus to guide fluid management. And if common etiologies are found out, blood pressure control for preeclampsia, antibiotics for sepsis, if on any obstruction, we relieve. And as I said, we keep in mind if we suspect ETP plasmapheresis. So all this is done before any special reports come back. And if we are suspecting HUS, we have to go for eculizumab. In fact, the patient fits into the criteria for eculizumab. Only thing, it's not available. So we have raised the indent through the Center of Excellence for eculizumab at this point of time. So the investigations have been sent. We have raised the indent. We have decided not to carry on with the plasmapheresis. We have stabilized the patient. Now, dialysis. Does she need dialysis? Yes, she needs dialysis. She is oliguric, creatinine is high. And the indications for dialysis in pregnant AKI are similar to non-pregnant AKI, AEIOU, that is azotemia, electrolyte disturbance, which is intractable metabolic acidosis, volume overload, and uremic encephalopathy or pericarditis. But remember, here we start early because we have to look at the baby also if the patient is pregnant. So this patient was post-delivery, but otherwise, if the patient were to be pregnant, the BUN should be less than 50. So that's important. That the principles of dialysis in pregnancy as compared to non-pregnant state are, we do daily dialysis, long sessions, weekly, more than 36 hours dialysis, lower thresholds of pre-dialysis BUN, and ultrafiltration rates should be lower. So this is important. In addition, the dialysate in pregnancy is a bit different. Potassium is higher, calcium is higher, and bicarbonate levels are kept lower to meet the physiological requirements of pregnancy. So this is important. The basic principle is if you are doing dialysis when the lady is pregnant, it should be more frequent, gentler, and should happen earlier to keep the BUN less than 50. In our case, that lady had already delivered and she was on a routine dialysis prescription. Which type of dialysis? So any type is safe. Peritoneal dialysis we do only early in pregnancy or postpartum. Postpartum again only if there are no other options or if the patient is hemodynamically stable, because the gravid uterus sometimes interferes with PD. So best modality is either intermittent hemodialysis or a continuous renal replacement therapy or SLED, depending on the hemodynamic stability. Any of the modalities between hemodialysis, SLED, or CKRT can be chosen provided the patient is hemodynamically unstable. And this is our experience, 290 patients of PRAKI, where hemodialysis was the main modality, but we have used others as well. And KDIGO agrees with that. You can go with IHD or CKRT, depending on the indications. Only hemodynamic unstable, you go for CKRT, or acute brain injury with high ICP or brain edema, CKRT. Otherwise, hemodialysis and CKRT are equal. So any of them can be done. Our patient was put on hemodialysis. Now, patient was put on hemodialysis. This was on the 3rd, 4th day of her delivery, and investigations have been sent. She is stabilized. She continues to be oligoanuric. 2nd week, she continues to be oligoanuric. What next? So when do we do a biopsy in PRAKI? So generally, 2 weeks is the time we wait, and that's recommended by literature generally. Most of the large biopsy series are from India because severe PRAKI is generally seen in India. Ours is one of the largest biopsy series in India, where we have done biopsies in 103 patients. And mostly biopsies, 50% of them show cortical necrosis, either patchy or diffuse. Others may be there. You may have TMA, ATN, glomerular disease. Sometimes you can see the distribution there, but 50% is cortical necrosis, and that has a very poor prognosis. So this is our series, which I said, which we published from our center. And this is an agreement with a meta-analysis by Preeti Meena et al., where again, acute cortical necrosis was a major biopsy finding. So a healthy woman goes into cortical necrosis, and that's CKD for her. So our patient, what did the biopsy show? It confirmed TMA and also had patchy cortical necrosis. You could see some host glomeruli in the biopsy. This cortical necrosis, as I said, is a dreaded entity. The patient continues to be either anuric if it is total or oliguric if patchy. Most commonly occurs with TMA, obstetric hemorrhage, or sepsis. Sometimes the ultrasound may pick it up with sonolucent band. Our patient did not have this finding. The renal biopsy showed host glomeruli. X-rays or CT can show calcification. However, that was not available at that point of time. Ultrasound didn't show anything, and we couldn't pick up any calcification even at 2 weeks. Biopsy showed the pachycortical necrosis along with TMA. So we knew that our patient is going to have probably a poor prognosis. So now we are in 3rd week. The results have come. ADAMTS activity more than 60%, inhibitor is absent, antibody is negative. So TTP definitely ruled out. We got the complement reports as well. I had shown you these are the normal figures. What happened to our patient? Everything came normal. To our surprise, complement was normal. Antibody was negative as well. So where are we now? Should we rule out that complement-mediated HUS? No, not so fast. Remember, normal complement does not rule out HUS. It might be a lab error. The collection may be improper. Sometimes the activation may be local and not systemic. So 30% of patients can have a normal complement even when the pathology is HUS. What about the genetic report? So by NGS, the exome sequencing showed no pathogenic mutation. So should we rule out HUS now? No. Again, wait. The MLPA report was yet to come, and that report came, and this showed homozygous deletion of CFHR1 and CFHR3 and pathogenic. So remember that the genetic report, it's always better to do by both modalities, NGS and MLPA, because this deletion is a large genomic deletion, and it's not a small sequence change. NGS generally detects point mutations, small insertions, deletions, and does not detect large deletions unless we order a special analysis. So better to send both NGS and NLPA if you want to pick up mutations. So this confirmed that she had a genetic cause for the pathology, and complement-mediated HUS was probably the diagnosis. So now what she would require eculizumab, which is a C5 inhibitor. We are aware of the doses, 900 milligram weekly for the first 4 weeks, and later on you give it every 2 weeks at a dose of 1200 milligram. Remember, it's a good thing that it's not dialysable. We need not adjust the dosing, and you can give it even if the patient is pregnant. Even to the baby, it's not harmful. It can be given during pregnancy, postpartum lactation. You should start. In fact, we should have started this on the 3rd or 4th day, but we were not able to do because it was not available. We have to raise indent, and generally it takes 3 to 4 weeks for the drug to reach us. So once you have excluded the other causes, TTP, infection-related HUS, this is the therapy which should be started upfront. Remember, if there is no genetic defect and the patient is improving, this drug can be discontinued. In our patient, probably once started, we need to continue it because she had a definite genetic mutation. So this is the treatment of choice. There are other drugs available. Revelizumab, PGs should be aware of this because it's long-acting and can be given every 8 weeks instead of every 4 weeks. Crovalimab, this is important because subcutaneous form is available. Narsoplimab, it is important, but it's a proximal inhibitor, but again, it's used in refractory cases, no pregnancy data. Pegcetacoplan, this again is a proximal C3 blockade, subcutaneous, that's important, easier to give, used for resistant cases. And denicopan and iptacopan, these are oral. These are also under trial. So as of now, we have only eculizumab and revelizumab, which are in clinical use. Fine. So coming to the last part, what about the outcomes now? So we have tried to put the patient on eculizumab. We are still waiting for the drug. It's not easily available. And the patient is continuing on dialysis. So what are the outcomes of PRAKI? Are they always bad? So in high-income countries, 90% recover. What about our country? Around 50 to 75% do recover. That's a good information. But 10% go on chronic dialysis. That's a big number. And if help, around 20% go for chronic dialysis. And if it is HUS and not treated, around 50 to 75% end up with end-stage kidney disease at 7 years. And this is echoed by that meta-analysis by Preeti Meena, where they showed that pregnancy-related AKI is an important driver of CKD in our country. So we talk about diabetes, hypertension, CKDU. Do not forget PRAKI. Never forget to follow up PRAKI cases. And in case the PRAKI progresses to end-stage kidney disease, transplant is the best option. But among all cases of PRAKI and all etiologies, that HUS has the high risk of recurrence post-transplant. Therefore, for Our Lady, if she goes for a transplant, eculizumab has to be given. It can be given prophylactically as well as post-transplant also, where it is safe. So we should ensure that this drug is available before we undertake transplant in this lady. What about the kidney outcomes we talked about? What about mortality? So mortality in HIC is 3%, LMIC is 33%, 10 times as much mortality. Fetal losses are also quite high to the tune of around 30%. And it's not only the kidney outcomes or mortality, long-term outcomes. PRAKI affects the mother cardiovascular system, especially preeclampsia, neurocognitive impairment. For child, it's a lifelong risk because small weight baby, that leads to metabolic syndrome later on, lower nephron number, CKD later on, and also cardiovascular disease. So it's a multi-system disease, not only a kidney disease. And that's why follow-up is important. And the AKI has given some framework for follow-up. If you don't find it very easy to remember that. Do not lose follow-up at least once a week for the first month, then once in 3 months, and later on once in 6 months. So that should be the schedule. But otherwise, if you're able to remember the table, more number of comorbidities and the need for dialysis, the follow-up has to be more frequent. So that's called PRAKI camps. This PRAKI camps is a term introduced by AKI, which means what do you do for follow-up? K stands for kidney. So you look for protein and creatinine, advocacy, medications, check the medications whenever the patient comes. Next pregnancy plan, discuss with the patient, discuss contraception, pressure, look at the blood pressure and sick day rules. So camps, PRAKI camps, that's a catchy term to emphasize that follow-ups are important. And we should have the capacity of developing a registry of PRAKI, which in India is trying to do. The Women in Nephrology India, we are trying to create a registry for PRAKI. So ladies and gentlemen, that's the last slide. So I've tried to emphasize that PRAKI is common. Around 10% of all cases of AKI are because of PRAKI. That's a huge number. And the most common causes are preeclampsia, sepsis, and obstetric hemorrhage. Do not miss preeclampsia mimics. So most of it is preeclampsia, sepsis, and obstetric hemorrhage, but do not miss HUS, TTP, and AFLP. Most important is that HUS. Do not miss it, or the TTP, because both have specific treatments. Go for testing, at least collect the samples, even if you are not able to go for testing immediately, because you can store the samples. You can store the samples indefinitely if you keep them at -70 or -80 degrees centigrade. So store the samples. You may get an opportunity later on as a part of several projects. And the treatment, stabilize the patient, dialysis as needed. And most important thing is, do not miss the specific entities where treatment is available, where the ESRD can be reduced to less than 10%. And this is the paper which the moderator was referring to. And most of the references what I've taken are from this paper, apart from the other numerous reports of PRAKI published in the world and in India. So thank you very much. And this is a PRAKI net, which is being developed by Preeti Meena, who's the first author on this publication, where we are trying to collect all the reports of PRAKI and all the cases of PRAKI and trying to analyze them with the help of funding. So these two projects are going on. One is the long-term PRAKI registry, and this is about the data of all PRAKI cases as per the etiology and the lab findings. So thank you. That was the last slide, and I'm really grateful for a patient hearing and for the time. I'll be happy to take questions if there are any.
Was a very clear and a lucid explanation of various parameters of pregnancy-induced AKI. We can move over to panel discussion now. Seema, can you just post the questions, please?
Yeah. So
the first question, I think you pretty much answered that in your talk, madam, that we can use various reference levels at various trimesters to know to judge whether it's a acute kidney injury. But my question is, can we use other parameters like cystatin C as a marker in pregnancy-induced care? And does the behavior of cystatin C varies according to trimester, similar to that of creatinine? And it can be reliably used as a marker for determining.
Yeah, so that's a very pertinent question. And again, as a part of any guideline, it's not come so far. There are some studies on the role of cystatin C in diagnosis of pregnancy, AKI. Now, again, and recently you are having some studies on that. But again, because GFR is high in pregnancy, so what happens is it's not as reliable as in a non-pregnant state. The cystatin C levels, unlike creatinine levels, they increase in pregnancy. Even when the kidney function is normal, the main reason could be it is produced by the placenta. There are some reports that it's also produced by the placenta, so may give a high circulating level. So you may get confused that it's like false PRAKI, that impression you may have that renal dysfunction is existing where there is no renal dysfunction. So that is one big problem. So interpretation is quite difficult. So limitation is it's altered by pregnancy itself. Then again, you have trimester-specific variation like you have for creatinine, and there are no well-established ranges so far for the pregnant women. So I won't recommend doing a cystatin C in pregnancy. It's not dependable. The main important feature is it is produced by the placenta. So it's better to go by clinical features as well as the trends of creatinine rather than cystatin C in pregnancy. If anybody else on the panel has other views, I would be happy to hear them. It would be nice to hear them. But it's an
No, no,
important
ma'am,
point to
absolutely correct.
remember that you have placental production of cystatin C.
Sudeep sir, you can comment on this.
No, Bab is absolutely right. Yeah, we can't rely completely on that.
So many people are not aware that the cystatin C levels may be in fact higher. So it's confusion. See, GFR brings the levels of cystatin C down, but the problem is cystatin C is produced by the placenta. So that confuses the whole picture. So as of now, we don't have any reliable, levels in different trimesters of pregnancy, unlike creatinine. At least that's an old tool, but we are well familiar of the advantages and disadvantages of creatinine, and we are comfortable using it. So till we have long studies and with big sample size and all that, and we have reliable values during different trimesters, I don't think it's a good marker to use.
How about the newer biomarkers, novel biomarkers like we talk about TIMP2, IGFBP7, NGAL, KIM1. So could this be of some help? Like before we get a functional AKI, can we find out structural AKI? What we are now talking about the new KDIGO AKI, structural AKI. So can this be applied for PRAKI, madam?
Yes, so it seems to be, as far as the literature goes, they say that it seems to be a better marker than at least the cystatin C. And we know that the source of this is, like, for example, TIMP, it's produced by the tubular cells and all that. And then you have that biomarker panel, that nephrocheck and all that. So in pregnancy, the advantage is it's not significantly affected. Placenta does not produce all that. And it reflects the true injury to the tubules. So that's good. It can help identify subclinical AKI. And again, the interpretation as per the literature goes, they say it's almost similar. The values, what we use in non-pregnant AKI apply here as well. But again, we do not have any pregnancy-specific ranges. So probably, and it's costly and it's not widely available. So only thing is that it's an early marker that's more reliable than cystatin C. So if we have to go for biomarkers in pregnancy, this would be good. But again, I think it's not available. And then you need to have pregnancy specific ranges. As of now, if you want to use it as a part of your research study, you can use and you can go with the non-pregnant ranges. But as you said, yes, it's an upcoming biomarker, but is not mentioned in any guidelines for PRAKI as of now.
Right.
I had one point to say, sir.
Yes, please.
Sorry, I think ma'am is absolutely right, but the creatinine or the GFR is not the only indication which is required to initiate RRT or to act in case of AKI. Like the simple things like tachycardia, tachypnea, uh, the basic baseline creatinine levels in first, second, and third GFR like 0.81, 0.82, and 0.84. They are good enough. So I don't know how much, even if these newer biomarkers come, how much they will bring a change in the management.
Yes.
Because there are multiple factors which decide initiation of fluid resuscitation or RRT or initiation of antibiotics if sepsis is there. There are multiple parameters for which these things take on.
I fully agree with Dr. Sudeep because, as I said, the AEIOU, and you have to keep the levels of BUN even lower for the,
Yes.
suppose, especially in pregnancy, if you are planning dialysis and all that, the dialysis indication is not only the value of creatinine. I mean, we have taken up patients with a normal creatinine for dialysis if they had other indications. So the AEIOU are always there. In addition, in pregnancy, the dialysis is taken up earlier, even earlier than what we go for in the non-pregnant state, because finally the two lives are at stake, mother and fetus, and the fetal viability and fetal growth also is important. So we should try to maintain the metabolic milieu, the internal milieu, as normal as possible. So that's why, and dialysis is, again, it's a therapy to maintain the internal milieu. So the creatinine is not the only determinant. And I fully agree with you, even if you have the biomarkers, I don't know how clinically useful they would be to decide regarding dialysis or not dialyzing the patient. So, but only thing, they may pick up AKI earlier. So, but again, that's an area of active research. How do we use them clinically later on, and how do the guidelines unfold later on?
Agreed.
So moving on to the next question, as Madam discussed in a talk that septic abortions are declining and hypertensive disorders of pregnancy are going up, partly driven by obesity, advanced maternal age. And preeclampsia now is one of the dominant drivers of PRAKI. So would you recommend any change to antenatal protocols at all the three levels, primary, secondary, and tertiary? And would you argue these are non-negotiable to meaningfully reduce the incidence of PRAKI and the burden of kidney disease?
Yeah, so that's a very pertinent question. And as we all know, and we are all experiencing that septic abortion and all is coming down, the sepsis protocol, the asepsis protocols are better. So now, like the developed world, the preeclampsia has becoming a more important cause. So we cannot prevent whole of preeclampsia, but some of the important things are that, again, I mean, we have the facilities available at primary care, secondary care, tertiary care, but we don't use the system properly. We don't have implementation and audit. So actually, the measurement of blood pressure, urine protein, so identification of high-risk women at the first visit, because many of the times pregnancy is the first time when the woman visits the hospital or the doctor. So that opportunity should never be lost. Blood pressure should be taken, urine protein. And I'm surprised that many centers, especially the primary level, creatinine is not available. So in fact, having a creatinine also, it would be good to have a baseline value of the creatinine at the first visit. It's not a part of the many of the antenatal protocols. Then, so at least once it should be, I mean, in the ANC panels, that should be there. And the ANMs, ASHA workers, they should be trained to detect the blood pressure changes, the red flag signs, the warning signs, pick up oliguria. Oliguria is an important clinical event which is sometimes not picked up, because creatinine is not the only way to diagnose AKI. You can have a normal creatinine AKI even with oliguria. So those things are important. And then we should have red flags for referral to higher centers. In addition, the low dose aspirin, that should also be not be forgotten. So whenever indicated, it's very important. It reduces preeclampsia and reduces PRAKI, and should be started at 12 to 16 weeks in high-risk women. So that's also important. So I think I would just summarize by saying that the training of the people at primary care centers, because and referral pathways should be there. Inclusion of creatinine as mandatory in the panels. And in addition, I think like starting of aspirin. These would be the major measures which would prevent preeclampsia to a large extent. And then there are papers on home BP monitoring. So these instruments can be given to the patients. I mean, not all the places because of the cost constraints and literacy constraints, but wherever feasible. So home BP monitoring also has been shown to improve the results, monitoring in cases of preeclampsia.
Thank you, madam.
So the other people on the panel can also give their inputs. What else would you, think would bring down the preeclampsia and its complications?
Absolutely, ma'am. I think I can tell this from my family's experience. I have a gynecologist in the family, and when I was discussing about one such case, I said, "Why did you not don't you include the creatinine?" So her answer was, "अरे आप लोग बढ़ाते चले जा रहे हो. पहले तो हमें बोलते थे खाली CBC कर लो. अभी creatinine आ रहा है. Hepatologist." So they do not realize the importance of doing a simple creatinine, which is maybe at 150 or 200 rupees test. So, with the lifestyle changes, the complicated pregnancy, and we are more and more aggressive in accepting the pregnancies. Like IVF has come in, the older ladies getting pregnant. So we have to become more sensitive. It is not a world where the standard 20 to 30 years of female are getting pregnant. We are having females getting pregnant at 40, 45, where they can be having underlying unrecognized hypertension, diabetes. So to reduce PRAKI, if it is a atypical HOS or other things, it's a different story. But it should not at least be an acute and chronic kidney disease. Underlying hypertensive or diabetic kidney disease, which gets aggravated. This is something, the last thing which we would want to have. So absolute right, ma'am. I think this CAMPS thing, that also includes the medication and next pregnancy planning, if just in case if she has had AKI, and many females are not even aware that they have had AKI in the.
Yeah,
that's very valid actually, Sudeep. Not missing a CKD during pregnancy is vital.
Yes.
So I think
Absolutely.
the gynecologist should be made aware that not missing a CKD during pregnancy is very vital. And as we have a widened definition of CKD, I think there's a lot of work to be done in this area. I think that's a very, very nice suggestion.
Yes. So I agree with both of you. Dr. Sudeep has brought up very important points. One thing is now the pregnancy age. That's getting delayed. We see it with our the younger generation. So one of the reasons for increase in PRAKI in the developed world is assisted reproduction and late pregnancies and all that, and that's happening in India as well. So the entire scenario of young female coming in all is going to change soon, and that's why preeclampsia is going to become very, very important. And I think the traditional tools available at PHCs and all need to be updated. And as Dr. Giri said, pregnancy is the opportunity when many of the ladies go to the hospital for the first time. So that opportunity should never be, missed. And the gynecologists, I think, see, we keep on talking among the nephro crowd. I think we should, now it's time, high time. See, whatever we are doing, so many webinars, seminars, whatever, we are not able to make a dent in the CKD. And not all of us realize that, I think. And we do talk about cross reaction with others or other specialties. And that's very important because we have become very tubular. And in fact, having gynecologists on the panel and looking at their point of view also would be, the next step probably in your webinars. So that, and even the physicians, because everybody should know the basic rules, which does not happen in India. An intern is the best doctor, which never happens in India because common things are not followed. So that's very, very important. And they should understand like blood pressure in early part of pregnancy and late part of pregnancy. And then again, the proteinuria, the importance of proteinuria, definition of CKD. So all these are very important. We should never miss CKD in such cases. So this should be an opportunity to pick up CKD.
In fact, I would like to congratulate the organizers. I have one of my gynae residents from my hospital attending the webinar.
Yeah, thank you. I think, Sudeep, you can answer these questions.
The question for me is when do we initiate dialysis and PRAKI, and are the indications usual, conventional, or adopt a earlier initiation? So I think there is not much to say. I will just reiterate what ma'am has already highlighted here, and in her position paper consensus statement published in Nature Reviews. See, the indications remain the same for all the residents here and my own ones here. The indications remain the same. Hyperkalemia, fluid overload, uremic encephalopathy, and uremic pericarditis. The 5 common indications. But in PRAKI, the incidence of uremic symptoms like pericarditis and encephalopathy is extremely rare because there is a state of hemodilution. So, what we have to understand is that these indications like hyperkalemia, acidosis, and fluid overload, they will definitely continue to be the indication. But there is another scenario which we have to remember. There is not one, but 2 lives at stake. One is of the mother and other is of the child, and they are in conjunction with each other, interacting continuously. The milieu of one is going to affect the other. So whenever an acute kidney injury occurs, it just shows that the milieu is not right for the baby. In fact, any change in the baby's milieu, mother's milieu is going to affect the baby. Rise of urea, especially for the resident, we have to remember that urea, creatinine, blood urea, nitrogen, these themselves are not toxic agents as much, but they are just representing that since they are high, we assume that other toxic agents are also high in the blood, and they are going to affect the baby. So as ma'am has rightly highlighted that we have to be preemptive, because by the time we come to know that this AKI has occurred and it is affecting the baby, it will always be much late, and some amount of malformations or developmental delays in the baby would have already occurred. So we generally follow that we have our threshold quite low, and whenever urea is more than 100 to 120 milligram per deciliter, in spite of absence of any indication, we start renal replacement therapy. And as ma'am said, that to ensure adequate dialysis, we need at least 36 hours of dialysis every week, kidney replacement therapy every week, because we need to maintain a mid-week urea level, pre-dialysis urea level of around 70 milligram per deciliter. And just to maintain that, this is the minimum 5 to 7 hours of daily dialysis, at least 6 days week dialysis is required to maintain a good fetal milieu, which is of which the surrogate marker is a mid-week urea, pre-dialysis urea of 70 milligram per deciliter. So in addition to these 5 indications, standard indications which we follow in the normal non-pregnant kidney, the indication of serum urea is very, very important, which is around 100 to 120 milligram per deciliter. Thank you.
An extension to that, would the modality of HD versus HDF make a difference in pregnancy?
Sir, actually, whenever the patient is, we are dealing with a pregnant patient, we are always worried about preterm labor, initiation of preterm labor. So here we are talking about pregnancy associated AKI. So I assume that in this case, patient would not be having the peritoneal catheter in situ. So I don't think inserting a peritoneal catheter upfront during pregnancy-induced AKI, which is most of the time, which will either need a CR, which includes radiation, or it will be a blind technique. It's a very good idea. So in a patient, a CKD who is already on peritoneal dialysis, maybe yes, I would like to continue with the same dialysis if it is not causing overloading or respiratory distress or is not affecting the outcome, and I am able to maintain the serum urea levels of around 70 midweek. But upfront insertion of a catheter and initiating a PT, I personally would not recommend it. I am not very sure what is the international literature. Then maybe ma'am can enlighten us on.
So actually, I think the question was about, so you have explained about PD and HD, and I agree with you. So regarding the HDF, hemodiafiltration, the evidence in pregnancy is not so much, but the clearances are better, the stability is better. And
Oh,
if
it was HDF. I thought it was PD. I'm sorry.
No problem. So both just I'll tell my views that HDF again, clearances, tolerability, all those things are better. And if indicated, you can use it. If the patient has been on HDF before pregnancy, you can continue that in pregnancy. So no contraindication, but the standard treatment, what we use hemodialysis because easily available and cheap. So if nothing else is required and you are able to meet the clearances with HD, go for HD. Otherwise, HDF, no contraindication to HDF except the cost. So do if required. Regarding PD, I think Dr. Sudeep already explained. So there are papers on PD, but only in the early part of pregnancy or postpartum after the involution of the gravid uterus. Because again, as the uterine size grows, the space for PD fluid becomes less, and also you have like a risk of causing injury to the gravid uterus, baby, and also inducing preterm labor. So generally, that's not the modality in the second half of pregnancy. It's absolutely, not recommended by guidelines. First trimester, yes. Postpartum, after the uterine involution has occurred, yes. So we have had experience of PD in pregnancy, but only in early part or postpartum. Last trimester, they are, in fact, I was so surprised, there are some case reports even in the third trimester of pregnancy, but that's not the norm, neither it's recommended.
I think the next question to me was regarding the fluid management.
The next question would be that it's one of the most treacherous clinical decisions in PRAKI that in sepsis you might want to give volume, but pre-eclampsia fluid administration may risk pulmonary edema. So when these conditions coexist, which actually they do when you are practically bedside near the patient, so how would you do your decision making? What are the parameters you would like to look at? What are the clinical signs, and would you use anything like focus to judge your clinical decision making?
Sir, actually, firstly, I would like to see at what time of pregnancy I am handling this AKI. So if it is peripartum time, then the diagnosis becomes very difficult. It could be sepsis, puerperal sepsis, or it could be pre-eclampsia. Now, pre-eclampsia, as I would request my resident friends to focus is that instead of being a volume depleted state, it is a volume contracted state. There is a low oncotic pressure, and whatever fluid we give is going to get. Sir, I think Tushar sir has to leave. If you can take his question from earlier.
Hey.
Sir, good evening.
Good evening.
Good evening, sir. How are you? So the next question.
We have reserved difficult questions for you.
Sir, I think Tushar sir can take the questions first, sir. I'll take later.
Yeah.
So the question for you are the key delays in the referral PRAKI patients in India, and how can a nephrologist collaborate with the obstetrician to improve this outcomes? What would be the structural or behavioral change that need to be incorporated at different?
See, the most important thing is that interdepartmental cooperation is required. We need to keep on talking to our friends that this is something which we need to handle, and as Manisha ma'am already said, can you hear me?
Yes,
sir, you are audible.
We can.
Yes, sir.
Your video is not working. Yeah, now it's clear.
Now it's clear?
Yes, sir. Yes, sir.
Yeah. So the most important thing for us is that we should be collaborating with all our gynec friends. And as Manisha ma'am said, the first good contact with medicine and the medical fraternity comes to the ladies with their pregnancy. So that is the point where we should be looking at the overall health of these young ladies, and we have to keep on looking at the possibilities that these could end up into end-stage kidney disease later on. So we have to keep on telling the family that this is not easy. The blood pressure rising is not something which is very simple. We did not take that into, say, lightly. Pregnancies are happening for last so many years. So ye kya naya hai? It's nothing like that. We have to keep on looking at. That's my feeling, is that we should be, and the efforts that we make with our things, that right from the beginning, the as the students join their DNB or MD or MS Gynec first and second year, we get one discussion with them. We ask our nephrology residents to keep on contacting with them, and we take formal lectures for them for the pregnancy-induced AKI, and that's why we try to keep on at least making them more aware that this thing could be handled with us. Yeah. Hello.
Yes,
Yes,
sir.
sir.
Yes, sir.
One
And
more-
AKI also proposes GAPS, that is kidney function adequacy, medication pressure, pregnancy planning, and sick day management. So, in practice, what does realistic and sustainable follow-up look after a woman is discharged with PRAKI, and especially the ones who may not really come back to us again unless symptomatic?
It's probably the community that needs to be made more aware that this is not something easy, and we need to keep on. In fact, we need to keep on insisting with the family members that this patient who has had some problems during the pregnancy, and now the pregnancy is successful and baby is home, but we need to look at the mother's health later on, and
Exactly.
that's a very difficult thing, I believe. What's your experience, Manisha ma'am?
What you said is absolutely right. But only thing is like in our setting, what we tell them is because after PRAKI, they never show their face. They come back pregnant next time again with problems. So that's what happens. And it's really sad to see people who were PRAKI as a primey, and then they underwent dialysis, also recovered, went back, and landed up after 2-3 years with a similar problem. So the thing is, one thing we tell in India for young females is that if they want another pregnancy, better be on follow-up and all. Otherwise, the chance of other pregnancy won't be there. So we give them the AKI has given guidelines, but in India, most of the guidelines are not practical, because if we ask them to come monthly, they don't turn up. So what we do is, for the first 3 months, we ask them to come monthly. After that, at least 3 months once. And in our hospital, luckily, all the medicines are given, like B complex, calcium. So we keep on giving them some medications or the other, so that they at least come for follow-up. And then we use AI, I mean the digital monitoring. So we are trying to maintain records of PRAKI patients and calling them up, even if they don't turn up, and ask them to send their reports. Now with the Disha Act and all, I don't know how far we are protected in asking them to send the reports digitally, but that is what we were doing. I mean, at least calling them and then engaging with them so they feel connected, and we are able to have some sort of a follow-up. But the point is very well taken. Whatever rules we make, whatever guidelines we make, unless they are implemented, it's of no use. So in fact, so now many of the schemes are government funded, and then you get how the scheme works are, if you deliver a certain service, you get paid for it, like at least the packages. So I think the package should also include postpartum care, and that should be, I mean, paid for the government only if those values are entered. So maybe, I mean, in India, people work with some sort of either incentive or some sort of punishment. Otherwise, they don't. So I think it should be from both sides. The data for pregnancies is entered. Postpartum data should also be asked. At least creatinine at 3 months, protein at 3 months, and at 1 year. So that may be one thing. Other thing, you counsel the patient that if they want to become pregnant again. So that could be the second thing. Third thing could be provision of medicines, at least the vitamins and all those things, so that they keep on coming back. But again, I mean, we have to
Really?
fire on all counts. Very difficult to have a follow-up in India.
What I keep on is talking to the gynecologist and telling them that if this patient comes, just send them across. Our department is just one floor above them. Just send them across and let somebody see. But that also does not happen. It's not a very easy thing.
I guess we should have involved one gynecologist for the discussion. We should
Yes.
have thought of that.
Yeah, I think next time
And
maybe we can.
even probably involve the ASHA worker also. I
Yeah.
mean, the peripheral PHC person. So they will tell their problems. We are telling them, pick up PRAKI. If creatinine only is not available, it's very difficult for them. And now we have point of care kits also. So
Yes, they are there.
those things probably, because we have to listen to those problems also. So otherwise, nothing is going to change. Most of the deliveries occur in the peripheral areas. Good setup is there. So I think those people also need to be included, policymaker, patient, and then gynec. I mean, gynec and nephro. That would be really good. So the concept is really good.
Okay.
So, as we close the session today, let me attempt a brief synthesis of what we have heard. PRAKI is a condition which occurs commonly and a common cause of acute kidney injury. And tonight we has reinforced three things. First is that early diagnosis requires active suspicion, and it's just not the passive waiting. Second, that management is cost directed, and there's no single protocol or guidelines that work in such scenario, and clinical judgment remains irreplaceable. And third is that story does not end at discharge. If the follow-up is most important. I would like to thank all the speaker and the panelist and the audience who has joined us tonight. Also, a special and warm thank you to our academic partners, Cogna Life Science, and they've completed 10 years and they have really their commitment to advancing clinical knowledge is reflected in their continued support for Nephrocon. And finally, to the audience.
Thank you. Thank you very much. Thank you.
Thank you, madam.
Thank you, ma'am.
Thank you so much. Thank you. Good night.
Thank you.
Good night.
Thank you very much.
Good night.
Thank you.
Thank you, sir. Thank you, ma'am.